All right, so let's move on to the deposition diseases. So let's go through some classification before just diving into individual forms of these deposition diseases. So you can break this down into the organized deposition diseases. Organized implies that there's substructure to these deposits. So amyloidosis would be a fibrillary or a fibril. So it has that secondary structure. Fibrillary also would be a fibril. Immunotactoid will be these larger substructures that people describe as microtubules. So you can see a size difference between these, let's call them all fibrils, and these would be forms of organized deposition diseases, okay? So then let's contrast that with these unorganized deposition diseases, and that's primarily going to be captured by the MIDD or monoclonal immune deposition disease. Now that refers to, that's the larger category of the more common light chain deposition disease. So there are even rarer forms of monoclonal immune deposition diseases where I might have the heavy chain present. You can have just heavy chain deposition disease, and you can have light and heavy chain deposition disease. But really, so I've categorized those here. Light chain deposition disease is the most common variant of the more broader category, monoclonal immune deposition disease. So you can see immune deposits that are present. Classic is, this presence of this powdery deposit that replaces the glomerular and tubular basement membrane. So I've made that statement here. The tubule basement membrane is typically involved as well, but they don't have this substructure. There's these powdery deposits. So that would be the most common form of the non-organized deposition diseases. Much more rare would be these esoteric things like fibronectin glomerulopathy, which is a disease of matrix proteins, and that has these unusual deposits that are present, usually are disorganized, but might have a fibrillary appearance. And they may arise from detectable mutations in the fibronectin gene. That's all I'm going to say about this very rare condition. All right, so let's go back to these organized deposition diseases and compare and contrast them. Amyloidosis would have these randomly oriented, all three, amyloid, fibrillary, and immunotactoid, you can see are derived from randomly oriented fibrils, right? These are going to be your thinnest, right? The most specific finding, however, is the presence of, there is some overlap, let me say that, between amyloid and fibrillary in particular, in terms of size of the fibrils. These are not perfect. But the distinguishing factor that you're going to rely on most prominently is the presence of Congo red stain. So, often you'll see your pathologist telling you, well, I have to wait for the Congo red staining to be confident that this is a case of amyloid, not just relying on the fibril size in order to make that determination, okay? These are also birefringent under polarized light. This classic apple green birefringence is shown here in the right panel, but this would be the appearance of the Congo red stain. Notice that you'll often see these, this large amount of acellular material replacing various compartments of the nephron. Usually glomerular, but sometimes you can see the same in the tubular interstitium or in the vessel. So you can see vascular amyloid as well. By the way, that vascular amyloid often coexists with cardiac amyloid. If you intuit that your heart is simply a specialized myocyte in its embryologic derivation. You can sort of explain to yourself that the presence of vascular amyloid can often coexist with cardiac amyloid. And noticeably, I'll just say one last point, vascular amyloid would present with without much proteinuria. You'll just have a kind of a rising serum creatinine without much on UA in terms of cellular components or proteinuria. All right, so the variants of amyloidosis are included here. AL amyloid is really the most common form of amyloidosis that we encounter. Of course, this is derived from a paraprotein. There have been much less common occurrences of heavy chain associated amyloid. Again, it's typically AL amyloid, the more common. Is certainly more common. Of course, we recognize another main category of amyloidosis that derives from chronic inflammation. This serum amyloid protein can create this abnormal deposits of protein. I guess I should make sure we recall the classic feature of this amyloid protein is the formation of these beta pleated sheets, which are resistant to proteolysis and clearing, and therefore you get this progressive deposition of protein that causes organ dysfunction. So certain light chains can do it, right? Not all light chains. Let me make this point. A patient who has a paraproteinemia can present with, myeloma kidney, that is a Cas nephropathy, and amyloidosis, can present with Fanconi syndrome because of a proximal tubulopathy. What determines which direction the patient goes is the property of the light chain, or use a more broad statement, the immunoglobulin. So if that immunoglobulin has a tendency to create beta pleated sheets because of its unique protein conformation, or its protein or its amino acid chain, then it will form beta pleated sheets and amyloidosis. It will not form a Cas nephropathy, or it may form a light chain deposition disease. So there are properties that are unique to this very diverse protein product that is your immunoglobulins, which are designed to be able to have multiple conformations in order to recognize non-self. It can have these various chemical properties, some of which that predispose it to aggregate with TAMS forceful protein and then form Cas nephropathy, or form these beta pleated sheets, which can form amyloidosis. We don't typically have a patient who has myeloma and then presents at one case a light chain in one stage of disease, light chain deposition disease, and then later forms Cas nephropathy. Occasionally, people can actually have two processes where they have both light chain deposition disease plus Cas nephropathy. That is uncommon for sure. And again, think of these properties of the immunoglobulin conferring these directions of expression. Only one of which might be amyloidosis. Okay. Again, chronic inflammation of any cause, whether that be chronic osteomyelitis or subacute bacterial endocarditis. A classic one is the patient who has recurrent skin abscess from IV drug use or skin popping. That's another one we've seen quite frequently as a presenting context for AA amyloidosis. Others exist, however. One that's being more and more recognized, especially in patients of Hispanic descent, is ELEC2 amyloidosis. We don't understand why it has that predilection for that racial group. However, it's well described, and we do have a couple of patients in our heartland population who are Hispanic with the ELEC2 amyloid on kidney biopsy. Beta-2 microglobulin is a classic one that used to exist, but really is pretty uncommon in these days because of the technology of high flux dialyzers that now can remove reasonable amounts of beta-2 microglobulin. Calcitonin is described as a cause as well in cases of medullary thyroid carcinoma. The Alzheimer's syndrome is a form of amyloid disease involving obviously the central nervous system, this amyloid beta protein. More recognized now is this transthyretin amyloidosis. Because we now have a non-invasive test, this nuclear medicine study, I think it's called a PYP NucMed study that's being used by our cardiology colleagues to diagnose cardiac amyloid. It is derived from this abnormalities, often in this transthyretin protein. And once again, one can have vascular amyloid that appears in the kidney as well. There are apolipoproteins that can cause amyloidosis, as well as these other less common proteins. Fibrillary, again, is another form of randomly oriented organized deposits that are present on fibrils that are present on kidney biopsy. Once again, it has this medium thickness. I'll highlight again that there is overlap, and so Congo red staining is often used to break the tie, not just EM thickness. Often these the fibrillary GN coexists with other conditions, such as hepatitis C. There's cases of fibrillary that are associated with autoimmune diseases, and we often have polyclonal hypergammaglobulinemia. Let's contrast this with immunotactoid, which has greater monoclonality. So this statement, polyclonal, usually polyclonal, is really, its primary purpose is to distinguish that from these, the immunotactoid, which is often derived from a monoclonal process. I should say as well here, this is noticeably absent, you should add this in. People are now describing this this heat shock protein, which is now perhaps a send-out test that is accessible even outside of the research domain, where you could check for this DNA BNAG9 that is a heat shock protein that's been found to be present on fibrillary kidney biopsies with a high degree of sensitivity and specificity. There's a paper that says this is essentially diagnostic of fibrillary with 100% sensitivity and specificity. I've never sent that out, but I believe it's now available as a send out to diagnose fibrillary. All right, microtubular structures that may be present on kidney biopsy. You have to distinguish these two conditions, immunotactoid and cryoglobulinemia. Both of them would look similar or can look similar on kidney biopsy. It's not always the case that cryoglobulins have the classic microtubular structures. I've highlighted that here. There is some variation in the ultrastructural appearance, but can take the microtubular conformation or these sort of comma looking shapes or even fingerprints. That is the main distinguishing or the main differential diagnosis when you see these microtubular structures. Am I dealing with immunotactoid or cryoglobulinemia. So it's often said in order to diagnose immunotactoid, you should exclude cryoglobulinemia. So how do you exclude that? Usually through serologic testing as well as looking for clinical context. Okay. So again, immunotactoid is correlated with monoclonality. Cryoglobulins can be both monoclonal or polyclonal. You'll recall the clinical categories of cryoglobulinemia. Type 1 is monoclonal cryoglobulinemia, classically in the context of Waldenstrom's. Type 2 is the mixed cryoglobulinemia that has both monoclonal and polyclonal components, classically associated with hepatitis C. And then you can have just type 3 cryoglobulinemia, which is, is just a polyclonal process. Okay. Rarely you can have this condition, collagenofibrotic glomerulopathy. I won't spend a lot of time talking about this extremely rare condition, except to say that it has substructure as well on EF. Okay. All right, let's move then. A focus on amyloidosis. Now that we've categorized this condition, I think there will be a fair amount of duplication, so we can probably move pretty quickly. Again, pathogenesis involves this ability for these proteins to take the beta pleated sheet conformation. You often will have other matrix proteins that are associating with these abnormally accumulating proteins, and then there's a resistance to the normal degradation, and so organ dysfunction results. Let's see what I can focus on here. There's a little bit of overrepresentation of lambda light chains in AL amyloid, and there's more kappa presentation for the MIDD, the monoclonal immune deposition disease, but that's not, that's not diagnostic. You could still have kappa AL amyloid, but there is this small tendency or modest tendency for lambda paraproteins to form AL amyloid as opposed to MIDD. Okay. And then I think we've talked about AAA amyloid enough, which is derived from this serum amyloid A protein. Let's go to clinical manifestations. This is a minority of patients who have myeloma who actually develop amyloidosis. You have a variety of tools to find these paraproteins, and we often use SPEP, UPEPs. That is the SPEP and UPEP are said to be the least sensitive. Immunofixation is significantly more sensitive for diagnosing a paraprotein. And now the serum-free light chains is the most sensitive test for detecting paraproteins. So again, if you're looking for this, a paraprotein, recognize that difference in sensitivity. SPEP, UPEP is least sensitive. The immunofixation is typically done as a standard on urine protein electrophoresis. Immunofixation is done on the serum protein electrophoresis when the SPEP is positive. And then, the serum-free light chains is a separate assay. I'll say another word about the free light chains real quick. Recall that renal impairment increases light chain, circulating light chains in the blood, because light chains depend on kidney function for elimination. And so when you're measuring free light chains as a test for paraproteinemia, you're not looking for only an increase in kappa or circulating kappa and lambda. That is not of relevance. That is commonly found in the setting of renal insufficiency. What you're looking for is the ratio that is abnormal. you're seeing either kappa or lambda present in large and significant, in significantly different amounts compared to the other light chains. So that's what you're looking for a positive signal for the serum-free light chains. Not an increase in light chains, rather a difference in the ratio of kappa to lambda. Okay, and sometimes that ratio, depending on which is represented, it's either a very low number, much less than 1, or a very high number, much less than 1. Again, depending on whether it's kappa or lambda that's present in excess. We've talked about AA amyloid. I don't know that I need to go over that much more, except to highlight that there are other diseases that are associated with AA amyloid. The classic being familial Mediterranean fever, although that's very common. Renal involvement is again common in the variety of amyloidoses, and so sometimes you cannot dodge. Let me use this as a point to emphasize that, you know, sometimes we dodge the kidney biopsy. We say, oh, do a rectal biopsy, rectal mucosa biopsy, or do a skin biopsy in order to diagnose amyloid. We're not too thrilled about doing a kidney biopsy in this diabetic with proteinuria. You can't, those are less sensitive for many forms of amyloidosis. So if you're really considering that diagnosis, the absence of amyloid on a rectal mucosa biopsy is not sufficiently sensitive in order to exclude that. So sometimes step up and do the kidney biopsy. Okay. I've already made this statement about how there can be very little proteinuria when I have vascular amyloid. You can have a tubular interstitial amyloid that also has very little proteinuria and presents with a sort of a bland UA and progressive worsening in renal function. And then rarely you can present with crescentic GN. And the hypothesis there is that the accumulation of all of this abnormal protein ultimately causes glomerular basement membrane disruption, and then the expression of neoantigens again, and a inflammatory lesion where frank crescents are manifested. Renal pathology is distinct. So this is a classic silver stain of a patient that has something other than normal matrix that's making up this excess mesangium. Because if it was normal matrix, one would see that that stains intensely black. The fact that that is not staining black would give you your clinical clue that there's something other than normal matrix that's present there. One possibility would be, again, amyloidosis. Okay. Kidney biopsy, once again, is the greatest sensitivity that you can see. I've already made this point that these other indirect or less invasive, maybe we'll call it, biopsy methodologies are not as reliable. We've gone over the Congo red positivity, the fibril size, and then again, I've already made the comment that this is one of your nodular glomerular scleroses. You know, it could certainly be diabetes, but when you see silver negative nodules, it's not diabetes. You have to think of these other possibilities, such as amyloidosis, fibrillary, immunotactoid, would be classic examples of silver negative nodular glomerular sclerosis, contrasting with that of diabetes, which would be silver positive. There's some controversy over whether MIDD nodules are silver positive or negative. I've sort of bridged that controversy by just saying that the nodules in MIDD are thought to be weakly silver positive. Okay. Immunofluorescence is not necessarily a reliable way to diagnose AL amyloid. Okay, so typically immunofluorescence is going to be positive, and you'll see positivity for either the kappa or the lambda, right? You look for kappa and lambda, Your clue to clonality is that kappa is present, lambda is weak, or vice versa. Lambda is really bright, kappa is weak. That's your clue that you're dealing with a monoclonal process, whether it be AL amyloid or MIDD. That would also, again, have this class restriction on immunofluorescence, either kappa or lambda, or PGMID, that's the proliferative glomerulonephritis with monoclonal immune deposits, a word salad. All that this says is that you have clonality. And then you have to distinguish, am I dealing with amyloidosis based on the Congo staining? Or am I dealing with MIDD based on the powdery deposits that are present on the glomerular basement membrane? Right, so I see light chain restriction. Again, the point I'm trying to make is this is just telling you it's a monoclonal, it's a MGRS, right? Monoclonal gammopathy with renal significance. You need to use the other properties to decide whether this is amyloidosis, okay? Now, there can be a negative IF, however, and it's not rare to see negative IF because these amyloid proteins with their abnormal conformation are not able to be recognized by, in some cases, by the standard immunofluorescent antibody. The antibody, when you're doing immunofluorescence, you're basically asking the pathologist to incubate this renal tissue with an anti-human immunoglobulin, an immunoglobulin that's recognizing human IgG or IgA or C3 or C1q. But when that antibody that may be present or that light chain is tightly bound to these other light chains forming these beta-pleated sheets, sometimes those epitopes that are recognized by the anti-human globulin are not available to interact with the immunofluorescent tag. So, so it can be negative. And so in those cases, you'll need to do additional assays. One might be, based on an immunoperoxidase, an alternate essentially detecting mechanism for immunoglobulin, or even microdissection and nuclear medicine resonance spectroscopy to find the antigen or the amyloid protein. So sometimes that's done in order to diagnose what specifically is the amyloid protein. You'll have to send this out for, again, dissection, microdissection, and NMR spectroscopy. Okay. Prognosis is typically pretty poor in amyloidosis. That's certainly a very important takeaway. And if you have cardiac amyloid, that is really very bad. Okay, the survival rates when you have cardiac amyloid are extremely poor. You'll see these patients if you haven't met a patient with cardiac amyloid yet. The classic, they're kind of like hepatorenal patients who have soft blood pressures. They're floridly overloaded. You're trying to manage that with diuretics. They have autonomic insufficiency and they get hypotensive. And so they often die of malnutrition and volume overload and sort of languish in the hospital, similar to HRS patients, basically. Heavier proteinuria is another adverse prognosticator. If you have a certain threshold of plasma cells in the marrow, this is an old marker of prognosis in amyloidosis as well as myeloma. So this is a messy biomarker that captures both, let's say, tumor burden. So if I have a lot of plasma cells or cancer cells in general, beta-2 microglobulin is a cell surface protein that is ubiquitous. It's present in larger quantities for any cancer, basically, but also is present when you have renal insufficiency. That is another thing that raises beta-2 microglobulin. So people have shown that, this is a prognosticator that captures both tumor burden as well as degree of renal insufficiency, and therefore correlates with prognosis in paraproteinemias, including myeloma. Higher BNPs, troponin, free light ratios, high uric acid levels. Those are prognosticators that are often informing treatment and whether patients should be targeted for bone marrow transplants or not. AA amyloid generally has better survival than the AL amyloid, assuming the patient is we're able to control this chronic inflammatory process. And there is some discriminating factor from measuring serum amyloid A protein in terms of prognosis as well. Let's finish up treatment, and then we'll end here. Usually these patients who have the paraprotein-associated amyloidosis are targeted for autologous bone marrow transplant. That's the same that's the same as the preferred treatment for many patients who have favorable prognosis for myeloma. So getting you got to get in the head of the BMT colleague that you're co-managing with these patients. In general, the treatments algorithms are, if you're not so healthy, you just get your Velcade treatments designed to reduce the production of paraprotein. Okay, if you're healthier, they go for these autologous BMT is technically not a cure, but is, let's call it, more robust treatments. So if you're not so sick, they'll target you for autologous BMTs, and it's rare that they'll go for an allo BMT in patients who essentially have refractory disease and are still healthy enough to tolerate that. So that's sort of the treatment algorithm that you'll see across BMT and that you'll be co-managing these patients around. It's often helpful to understand their thinking, and that's why I go over that topic. So autologous BMT is generally the preferred therapy for the healthy patient. And then if you can't do that, you're going to try and just control the paraprotein production through Velcade, thalidomide, or thalidomide analogs are typically part of the treatment regimen as well. And then you'll have varying antimetabolite introductions like melphalan. Sometimes you'll see cyclophosphamide, so that's Cybor-D. That's the Cy and Cybor-D. Bor is the bortezomib, D is dexamethasone. Again, AA amyloid will just treat the underlying disease. People have looked at colchicine as a treatment for FMF with some modest success. But that really is all that we have for the AA amyloid patients.